All right, we're going to talk about some anemias and clotting disorders, specifically sickle cell anemia, ITP, which is idiopathic thrombocytopenia purpura, and hemophilia A. So first, sickle cell anemia. These patients tend to be some of my favorite patients ever. Um, I think they need more love and guidance than most because there is a poor um, response to sickle cell patients as adults, and we have to help them transition from pediatric care, where we care for them and love them and try to make them feel better and believe their pain, to the adult world where that's not always the case. Um, there's a lot of bias included in this, in the treatment of patients with sickle cell, and a lot of that probably stems from the fact that they are people of color, um, and because when you have severe pain for the majority of your life, your ways of expressing it is different from the general public, so they're frequently not believed. So I'd like to caution you against that. So the pathology of sickle cell disease is that it's an abnormal shape of the cell. It's shaped like a half moon or a sickle. It clumps in the small vessels, and then that leads to tissue death. Close to 2,000 babies are born with sickle cell anemia every year. That's a lot. Stress, infection, dehydration, physical exertion, excessive cold exposure, or hypoxia increases the jamming of or clumping of the cells, which then leads to more tissue ischemia. The risk factor is being a person of color. It's most common in African, Mediterranean, Middle Eastern, Pacific Islander, and Indians. And you have to have recessive genes from both parents. These are some of the cues that we see. Obviously, the cues are going to be a little bit different from infants to an older child. An infant, we're going to see frequent infections, failure to thrive, irritability, pallor, hepatosplenomegaly, jaundice, and growth retardation. And in the older child, we're going to see them have more reports of joint pain, back and abdominal pain. They're going to have nausea and vomiting, frequent respiratory infections. They have other infections as well, but respiratory tends to be the most common. And they start developing enuresis, which is bedwetting, and that is um, not related to sleeping too heavily or their anatomy being different or them just regressing. It's related literally to how the kidneys are working in a sickle cell patient. So this can occur all the way through adulthood. Please remember that every area of the body can be involved with sickle cell. Soft tissues, there's going to be swelling in the soft tissues, possibly the organs, joint swelling, and all of this is going to lead to pain. This is a massive list of complications that a sickle cell anemia patient could suffer from. When you see stroke, I think you think most frequently of the adult population, but children have strokes. As young as 1, 2 years old, even younger than that, they can have a stroke. Various organs are involved with the ischemic process, and parts of them die over time. They're acutely at risk for sepsis. Acute chest syndrome is something that we definitely want to prevent, and we'll talk about that in a couple of slides. Functional asplenia is basically by the time a child's about 5 years old, their spleen has suffered so much tissue death and infarction that it doesn't work anymore. It doesn't even really exist as an organ in their body doing anything. So I think it said in your Ricci textbook that by 9 years old, there's 90% of kids who their spleen is not functioning. They develop, and there goes my dog, choking to death. The kids develop reduced visual acuity. They can get leg ulcers, gallstones. They suffer from delayed growth overall. Priapism, which is erections that won't go away, and enuresis. These are all really detrimental complications. So these are things that we really want to prevent. If we see what looks like these things, we want to start treating it immediately. So acute chest syndrome, it's a complication of sickle cell disease that involves chest pain, cough, fever, the oxygen levels get really low, and there's abnormal substances like infiltrates that just show up in the lungs. So it looks like a pneumonia. It's a condition that progresses really quickly, and it's the most common cause of hospitalization and death in people with sickle cell disease. So when the sickled cells are trying to travel through your body, sometimes they get stuck in and around the blood vessels that lead to the lungs. And this can be the reason why acute chest syndrome starts. So frequently it looks like an infection. There's cough, fever, hypoxemia, tachypnea, wheezing. When we see these signs in our sickle cell patient, we need to get the doctor on board with treating them. So we might need to give them a blood transfusion. They're definitely going to need IV fluids because sickling can be helped with hemodilution. It can be dehydration definitely worsens sickle cell disease and makes the pain worse. We're also going to treat acute chest syndrome with medications like ketorolac or an opiate. We're going to give the kids an incentive spirometer, and we're really going to want them to use it. So that's a really important thing that we're going to go into the room and make sure they're doing every hour. We're going to put them on supplemental oxygen therapy, and we're going to give them antibiotics for bacterial infections and possibly antivirals if it's a viral infection. We want them to use an incentive spirometer at home as well as in the hospital because we need them to keep their airways clear and get rid of all the buildup around their lungs. We need them to strengthen their lungs regularly. They might need to take hydroxyurea is a very common medication that is given to patients with sickle cell anemia, and it can help in the long run to reduce pain and avoid hospitalization from acute chest. Splenic sequestration. So this is kind of what I was talking about when I said that, so we have one side of it where we expect that somewhere between 5 years and 9 years old, every sickle cell patient's spleen will become a non-functioning. Prior to that, though, super young kids, anywhere from 6 months to 5 years old, can suffer from splenic sequestration crisis, and it can be really dangerous. So their spleen develops little tiny infarcts, which are expected. Their blood gets trapped in the spleen, and then this causes like a super dangerous drop in the circulating blood volume. Their hemoglobin drops by close to 2 grams per deciliter, and they develop splenomegaly. The only way to treat splenic sequestration crisis is we've got to restore their volume with fluids and potentially blood transfusions. And the medical community is kind of on the fence about whether or not the spleen should be removed before age 5. So a total splenectomy, if we removed it, puts them at an increased risk for infectious complications as they age. But if we leave the spleen in and they are in crisis, their blood volume is going to be too low and they're going to require too many transfusions, and it's all just going to go downhill. So what they're trying to think about doing is partial splenectomies, so going in and just removing portions of it, whatever portions might have the most infarcts within it. And then as the child ages, we expect that their spleen's going to stop working. What's left of their spleen will stop working, and we're fine with that. So it's kind of a difference between functional asplenia and asplenia because we had to take it out because it was causing massive problems with your circulating volumes. It's touch and go. Vaso-occlusive crises is what is normally happening when we see a child or an adult present to the hospital setting. They're coming in because somewhere in their body, their arm, their leg, their hands, their feet, their back, different places, there is an occlusive reaction inside the vascular structures from the sickling cells, and it creates pain and swelling and can be dangerous as well because we can lose function and mobility. Hydroxyurea is frequently taken by patients with sickle cell anemia, and we give it mainly for vaso-occlusive crisis prevention. So hydroxyurea stimulates the production of the fetal hemoglobin that is non-sickling. So they take it on a regular basis all their life at home. These are some of the diagnostics that we have to do to prove sickle cell anemia exists. So it is included in newborn screening. If that comes back positive, then we do what's called a hemoglobin electrophoresis, and that confirms the diagnosis. Normally when we have a kid come into the hospital and they have a history of sickle cell anemia, we're going to see a hemoglobin anywhere from 7 to 10 being their normal. Some kids that have been dealing with it longer and have more issues, they live with a hemoglobin of like 6. And then during their crises, they can get down to levels that really scare you as a nurse. It's like, 3 and 4. The reticulocytes are elevated, and the SED rate is elevated. These are things we normally see in the diagnostics and the labs. If we are concerned about a patient developing acute chest syndrome, we need to have a chest x-ray. These are some of the hypotheses for sickle cell patients. We've got risk for complications of sickling crises, impaired gas exchange, fluid volume deficit, pain, and risk for infection. So our goal as the nurse is to manage and minimize their sickling crisis. We're going to use oxygen, hydration, pain control, and we're going to monitor labs and give antibiotics. So the medical management for sickle cell anemia is the use of opiates for severe pain, Tylenol or NSAIDs if it's mild to moderate. Oxygen. Most of the time I'll put my sickle cell patients on oxygen regardless of whether their O2 sat is normal or not. And I do it just to help along the crisis. I want to make it easier for their body to get oxygen where it needs it by just providing it, whether symptomatically they look like it or they need it or not. Rehydration and hemodilution is really important. We're going to monitor labs. We're going to give them prophylactic antibiotics, and we don't just do that in the hospital setting. Most children take penicillin all the way up till at least age 5, and some take it longer. We give hydroxyurea, and it's possible that we're going to do transfusions, splenectomies, and cholecystectomies because of some of the complications we're going to see in those organs. So the actions or interventions of a nurse, first and foremost, we need to prevent. We need to prevent vaso-occlusive crises. We need to prevent acute chest. And we might not necessarily be able to prevent splenic sequestration crises, but we should be very vigilant about our physical examination of a sickle cell patient to watch for splenomegaly or severe pallor and fatigue. Those are indicative of splenic sequestration. We're going to provide education to the family on illness, how to take care of their child at home if they are ill with something else, like a respiratory infection, a cold, a GI bug. Things of that nature are going to create enough stress and dehydration in a child that we're going to also develop a crisis. We want to make sure that they are fully vaccinated and that they're taking penicillin prophylaxis. We need to make sure that they stay hydrated at all times. They need extra hydration. Hemodilution is the key. We want them to avoid exposures to temperatures that are too hot or too cold. So sickle cell patients that go out in the snow or live in very cold or very hot environments, Bakersfield, very hot. Sun exposure can also cause stress that leads to the dehydration that leads to crisis. And we want them to avoid overexertion. We need to teach them when they need to come and get medical attention. And that is basically any time that they suspect acute crisis is getting ready to happen. The problem with providing all this education is that we might be able to manage it when they are small children. Imagine the sickle cell patient who is now a preteen or a teenager, and they want to be in charge of their own life. The things that they want to do are be with their friends. They're not eating healthy. They're not drinking enough. They're not getting safe exercise. They're staying up too late. And so then now we've got additional stress from exertion and fatigue. They might be participating in what lots of teens participate in, which is partying. So we end up with alcohol or drug use, which further exposes us, gives us more stress, and leads to more dehydration. And then preteens and teenagers are just emotional in general because of hormones. So when you add a chronic lifelong illness on top of that, your stress levels and emotional stress are going to be even higher. And then we add in the fact that you're dealing with a disease that you know you have had family members die from you before they're 20, 30 years old. You've seen them develop drug addictions, not for any other reason other than the medical community does not treat them appropriately, so they have to seek out pain relief some other way. So these kids are seeing that. A lot of them are being raised by grandparents because mom and or dad are either addicted to something or they're passed away. And the family members that are losing legs and have gone blind and all of it due to sickle cell. That's a lot of emotional stress for a child or a teenager. So we need to give a lot of psychosocial support. And as far as pain management is concerned, the best way to treat and manage over time a patient with sickle cell disease is to believe them. We assess their pain frequently using the same tool over and over. So the tool needs to be appropriate for age and understanding and cognition, but it also needs to be appropriate for, well, we need to make sure that the patient understands the assessment tool. And then nurses need to understand that if your patient says their pain is a 10 and they are sitting on their cell phone playing a video game or talking on the phone with a family member or a friend or watching a video with a flat affect and really they don't want to interact, that doesn't necessarily mean that they're not having any pain. They've been dealing with it for so long that their response to severe pain is different. And they've also been dealing with healthcare providers not believing that they're in pain. So they come into the healthcare environment already feeling attacked and not believed and like it's just going to be more of the same. So we need to try to prevent that by immediately getting pain control on board. That should be the first thing that we do with any sickle cell patient, pain control on board. Then we can worry about starting an IV, which I'm going to tell you right now is not easy in a sickle cell patient. They've had so many of them and their poor veins have had so many occlusive crises that they're just not great. You might find a vein in a thumb. And if they tell you what vein you're going to be able to use, believe them. They know best. We're going to try to provide non-pharmacologic methods for dealing with pain as well, and they're going to guide that also. Some patients really want warm packs on their backs or their joints, and we need to find a way to get that for them, give them good warm blankets, and try to find a position of comfort. I also make sure that I am giving their pain medication, even if it's prescribed PRN, which at most hospitals that have a hematologic oncologic floor, we do not give them PRN. They are scheduled opiates. So even if it's PRN, I give them every time the PRN can be given. I don't ask the patient ahead of time. I bring the medication to the bedside and I ask them as I'm there, I have your pain meds, would you like them now? That way they don't have to stress out over having their pain relieved or managed. So kind of try to preempt that for them. Supply them with lots of hydrating drinks and then let them rest. They need it. All right. We are also going to talk about some clotting disorders. The ones on this list that we are going to focus on are ITP and hemophilia A. Hinox-shown line purpura is a type of purpura that occurs usually in relation to a virus and can be associated with nephrotic syndrome. DIC, I believe you'll learn about in fourth semester. All right, ITP, it's idiopathic thrombocytopenic purpura. This is an immune response where we produce antiplatelet antibodies. So the antibodies go around and they eat up our platelets. We don't have any platelets left, or not enough of them left. We start developing petechia, purpura, and bruising. Most of the time, these kids have a spontaneous recovery because this was due to a virus. So the virus happened anywhere from 1 to 2 weeks later. They develop this purpuric rash. Well, it's not really a rash. Purpuric hemorrhages all over their body. And then it just starts to go away. Sometimes it takes a couple of months for it to go away, but it goes away. There can be complications like really bad hemorrhage, bleeding into the organs, and intracranial hemorrhage, but we don't see those a lot. The treatment, if the platelet count is below 10,000, then we might give them corticosteroids, we might give them IVIG as a single dose, and we can do platelet transfusions, but we normally don't do that unless there's like life-threatening bleeding. We need them to follow up with a pediatric hematologist, even though it's self-limiting. If it does happen to last longer than a year, which is not likely, but if it does, we do a splenectomy. So the normal laboratory findings that we're going to see in a kiddo with ITP is extremely low platelet counts, less than like 50,000. The WBCs with differential is normal. Hemoglobin and hematocrit are normal. It's really just the platelets that are affected. And then when we see that, we're going to go in and do a bone marrow biopsy, usually just to rule out leukemia. The education that we provide to families, because most of the time we're not treating these kids, it's just observation, and then we redo their labs. So these kids are going to be at home pretty quickly. We want the family to avoid aspirin. We don't want them to give NSAIDs or antihistamines. All of these meds can precipitate anemia, and we don't want them to become anemic. They're already having issues with platelets. We don't need both. So they can all just use Tylenol for pain control. It's fine. We're going to teach the family to avoid any trauma that could happen because of activities. So we ask them to avoid contact sports, at least while the child is dealing with the ITP. So they can swim, they can do physical activity that's going to have less of a risk. We explain to parents the signs and symptoms of serious bleeding, and we tell them when to call 911. Okay, hemophilia A. This is an X-linked autosomal recessive disorder that results in the deficiency of coagulation factor, what is that, 8? I'm horrible at Roman numerals. So mom carries it, gives it to the males. So the risk factor, being a male. Hi guys, we're just always giving you all of these disorders. So once you have the deficiency of the factor 8, you're going to have an inability for your platelets to be used in clot formation. So they're going to go through Your body's still going to go through the clotting cascade. It wants to do it, but even though the clot tries to form, there's not enough fibrin in it and it just kind of dissolves. So you just keep bleeding. The diagnostics and labs that we're going to do are a CBC to look at platelets. We're going to look at PT-PTT, fibrinogen, and the clotting factor. Okay, these are the cues that we're going to see in a child with hemophilia A. They're going to have potentially GI bleeds, so we could see blood in the stool, we could see blood in the emesis, they could have abdominal pain from that, diarrhea because of the grody blood inside the intestines. They're going to have some malabsorption issues. We're also going to see joint bleeding. The picture of this little kid with the really swollen elbow, that is hemarthrosis, which is the swelling from blood in the joint, and it can lead to a lot of dysfunction, and it's very painful. We watch for hematuria. They can develop frequent epistaxis, which is nosebleeds, and headaches and irritability. The treatment is factor replacement. If you want to see a cool little video of a mom giving factor at home to a baby that's still in diapers but able to be toddling around, it's on the Wakelet for Heme Neo, and she's really good at it. They've got a portacath. She's got a great method for kind of tying him down and keeping him happy while the treatment is happening. It's just a push through a portacath, a PICC line, or an IV. So our actions or interventions as the nurse is to prevent bleeding, to give education on how to do factor infusions at home. So this is going to be about line care in the home setting. Not every kid has to have factor infusions at home though. Some of them, their bleeding episodes are so infrequent that they can just come into the hospital and have it. Those kids can also be managed using a desmopressin nasal spray, which is nice. We educate the family on rice therapy, so they need to rest it, ice it, compress it, and elevate it. And we don't want them giving aspirin or ibuprofen at all. And we need them to follow up appropriately anytime there is a bleeding episode. They need to follow up after that. So if a patient is having frequent hemarthrosis developing, blood in the joints, we need rice therapy to be happening. We don't want them to move it, but because their joints are being affected, when they are not having active swelling and bleeding, we need to be doing range of motion with those joints, passive and active, so we can keep them healthy. We just don't do it when there's active bleeding. We want to prevent the complications of joint dysfunction and loss of mobility, and then stroke is also a complication, and we want to prevent that as well. So making sure that they are well educated on follow-up, having a hematologist on board, and watching for the cues of increased bleeding.